27th webinar of Indian Arthroplasty Association. I'll welcome my guests from US, UK, Australia, and UK. Let me speak about the Indian arthroplasty first. We welcome you, all our members and our colleagues who are watching this video, this webinar presentation. This Indian Arthroplasty Association is presently having the membership of over 800 persons now. The history of Indian Arthroplasty Association, it started almost 28 years back at Chandigarh. The doyens of arthroplasty, Dr. Dholakia, Dr. Lord, Dr. Mani, Dr. Sancheti, Dr. Dhillon have been strong pillars who started this, and we all supported at that time. And we can't thank Dr. Chitranjan Ranawat enough for teaching us the art of arthroplasty, and not just the art of arthroplasty, but also the discipline of arthroplasty and the way of publications and way of presentations. We wish him good health. Amar is here. We are happy to have Amar with us. The webinar series that Indian Arthroplasty Association started during the COVID time. And at that time, the physical meetings were not possible. And we had an idea that why not we start the virtual meetings. And we have been having almost today's 27th webinar of our Indian Arthroplasty Association. Every third Thursday, we hold it at 7:30. We've had all these webinars already. Now we have the 27th webinar, and the final annual conference, the physical meeting, will happen at Coimbatore under the organizing chairmanship of our friend Dr. N. Rajkumar. He already has arranged a lot of things for this, and I'm sure that a lot of our foreign faculty have already received our invitation for the same. And friends, I'll request that when so much is happening, you become the members of Indian Arthroplasty Association as soon as possible. Just join us through our website, which is very easy. For today's webinar, which is the 27th, we are going to discuss the principles, techniques, and future directions in revision total knee arthroplasty. We welcome our faculty from abroad. The invited lectures are 4. Our Indian faculty and some foreign faculty will be presenting the case-based cases, and we'll be discussing on these cases. We have the excellent panel to discuss these difficult cases. Dr. Klauser from Germany, he'll be speaking first. Dr. Neil Sheth, Dr. Fonthekon from Thailand, Dr. Amar Ranawat from US will be speaking on managing bone defects in revision total knee arthroplasty, and it will be followed by 4 very interesting cases, which our learned panelists will discuss it up. The webinar will be convened by Dr. Manal Sharma. Manal, I'll request you to take it over.
Thank you, sir. Thank you for giving me this opportunity. Without wasting much time, I would like to invite our first faculty, Dr. Wolfgang Klauser. He is the Chief of Orthopedic Surgery at Helios Baltic Sea Hospital, Damp, and he was previously a Deputy Director at Endoclinic, Germany, where I happened to work with him. I invite you, Dr. Klauser. Thanks a lot for joining us and sharing your views on the principles of revision total knee arthroplasty. Over to you, sir.
Thank you very, very much for the very kind invitation, I'm sorry to say, and also for your kindness to be part of this esteemed faculty. My title is going to be Principles of Knee Revision. Can everybody see my screen?
Yes.
Can you all? Yes, wonderful. Okay, thank you. So, in the sake of time, I will try to keep it short. We only have about 8 minutes, and I will try to focus on the keys of revision knee surgery as I think they should be. And I think that the good thing about all of us being together today is that we probably do a lot of revision knee surgery, so we all know what we are talking about. So I think that a lot of what I'm saying will probably be something that you are familiar with. I think as an experienced knee revision surgeon, we all have a thought process we probably ask ourselves, why did it fail? Then we think about the removal of the prosthesis. We are going to hear more about that later today. And then we actually think about reconstructing the whole case, which we consider to be the surgical technique. But I think for the less experienced surgeon, I think we all need to suggest that you should have something like an algorithm when you do knee revision surgery. I think the algorithm that we got from Kelly Wins is probably the most suitable one. I think it's free for download in the web. And I think that I have learned a lot by actually using this type of algorithm approach, where you actually have different diagnoses on the left side, and you actually have suggestions of what should be done in order to do a proper workup for the patient and actually make a diagnosis in the end and find the proper therapy. Keep in mind, if you don't have a diagnosis, you don't touch the patient. We know by literature that if you don't have a proper diagnosis and you try to do surgery without a plan, you're bound to fail, and the outcome for the patient will be very poor. The second point I think that we need to know is that we all have to keep up with literature. We all have to have a certain knowledge, and we all have to experience our cases, go back and repeat our cases in the brain in order to avoid making the same mistakes. The worst thing you can do is that you repeat the same mistakes that were done by the previous surgeon. We know that the reasons for failure in total knee arthroplasty over the past years have actually changed nowadays. We know that early instability and midterm instability probably is getting up more and more in the front, as well as infection, something that we don't have the time to discuss in depth today. But I think that those two diagnostics are probably the most preeminent ones that we now face nowadays, apart from loosening. The type of revision that we perform routinely in at least Europe, and this is data from the Scandinavian Arthroplasty Registry, shows though that we probably do a lot of just revisions by exchanging the inserts or just exchanging one or two components, but not doing a complete revision. The problem is with the polyethylene exchange, the isolated polyethylene exchange, that we actually have poor outcomes when we just exchange the poly and think that the knee is going to get more stable and the patient is going to get rid of the problems. We also know that if we use primary components in revision knee surgery, we are going to have a less success for the patient. So the conclusion of this is, and this is what I mean with knowledge, is if you do a revision knee procedure, use revision implants in revision and don't use primary implants. And it's always better to do a complete revision instead of doing a partial revision. Third point I would like to point out is that we have different tools in revision knee surgery depending on the system that you're using. We have stems, we have sleeves, we have augments, constraints, and finally we have cement in order to do something like a hybrid fixation technique, whatever you prefer. The point is that all of these tools that we have available actually provide different types of options that will help us to guide us through the revision case. We know that stems in revision total knee arthroplasty are extremely important because they actually offload the tibial or femoral component by up to 30%. And that is going to protect our system. Keep or be aware that stems are dangerous. It's a stem-guided surgery that we do at the time of revision knee surgery, and you become slave to the stem, which can mean that you actually are being misguided when you use the stems in an extra-articular deformity. We have different types of stems. We should all be aware that they provide different reasons and different fixation types when we use them. We know that we actually want to fix our components in certain regions of the diaphysis. I myself prefer longer stem extensions now in recent times because I feel more comfortable. But you need to be aware that when you lose longer stems, you need to ream lateral or medial if you want to actually position your component in the proper direction by using offset stems as well. The fourth point is constraint. I think constraint comes in the last set. Once you have done your complete surgical technique, then you actually couple the tibia to the femur, and that is going to give you the adequate stability at the end of the procedure. The femur, we all know, is going to control the soft tissues. It's going to position the component in the proper position with respect to the extension gap, and the size will actually help you to close your flexion gap. So the surgical technique should always include the establishment of a vertebral platform, the balancing of the knee and flexion and extension. Keep in mind that if you increase the constraint, that you increase also the shear stress on the bone and the cement interface, which basically means that by increasing the constraint, it's obligatory that you should use stem extensions as well. Fifth, finally, my point would be that we actually need to talk about fixation in the revision setting. And I would point out on this benchmark paper, we're going to hear more about sleeves later on, but Morgan Jones actually provided excellent advice with respect to zonal fixation and revision total knee arthroplasty. We know if we look at these type of bone defects that we need something to provide sufficient stability in the metaphysis of the bone as well as the diaphysis, which is probably the leftover sort of space of the bone which is adequate. So cones and sleeves are great tools to help us at the time of revision knee surgery. I'm using a lot of those. The reason why I prefer the cones is because of their variability. There's different types. There's new generations now coming out. So that would be the first advantage. The second advantage is that I find them very easy to use. It's a simple instrumentation for the cones. It's a stem-guided surgery as well, and it's easy to place the trowels in place once you have actually created the adequate cavity. A third advantage for me for using cones is to actually use it in a cementless setting. They were actually intended to be cemented in the beginning, but even in those worst case scenarios, the cementless application of cones can be helpful. And if you have bigger bone defects, the big advantage here is that you have stacking options. So you can actually put one on top of the other and create something like a poor man's distal femoral replacement, if need may be. So you can cement them on top of each other and place them in situ. And the final advantage for me is that they actually have the chance to, you do have actually the chance to use the cones independently from the type of prosthesis by placing the cone accordingly where your defect is, whereas you can't always do that with sleeves. Which then, of course, leads to the fact that you can get shorter on your stem extensions if you have a revision case, as is shown in this case. Does it incorporate? Yes, of course it does. And I think there's a tremendous amount of literature nowadays, which I won't go into because of time issues. So my principles in knee revision surgery would be that we need to actually understand that we have to do a complete revision, that isolated insert exchanges are the worst, that we need to use revision implants at the time of revision knee surgery. We need to use stem extensions, but we need to know how to use them, keep aware or be aware that extra-articular deformities might be an issue here. I've been talking about zonal fixation. You're going to hear more about that later on. I think that you always have to keep in mind that the constraint issue is going to be the last decision that you have to take at the time of surgery. Thank you very much.
Thanks a lot, Dr. Clauser, for that wonderful insight into the principles of revision total knee arthroplasty. Dr. Clauser has to leave for some another meeting. We would like to have some questions from the panelists or the faculty for him.
Dr. Clauser, to begin with, would you like to guide us, our members, especially the younger members, how you prevent the penetration of the femur by using these, when you are using the stem, because the femur is quite having the anterior bowing, especially if in extra-articular deformity. So what are your tricks for that, if you would like to explain?
I think that basically it all starts with the alignment. So if you have a bowed femur, you probably need to make sure that you know exactly how long your stem extension is going to be and in which way you want to ream and prepare the femoral canal. So that basically means that you either have to actually elevate your reamer and ream in a straight way in order to actually use an offset femoral component posteriorly, then turn it posteriorly in order to avoid that penetration of the anterior femur. Or else, if you have a system which allows for curved stem extension, then the reaming direction, of course, is going to be completely different, and you would actually sort of bevel down with your engine or with your power tool in order to actually get a straight shot into the curved anatomy. But no matter what you do, you need to be very careful. Power reaming is something with a good bony substance. I like to start in a soft, mushy bone by using a manual reaming device.
Dr. Anil Arora, you had a question.
Yeah, Professor Wolfgang, just one question. You showed us that you use long stems and you showed us that you use cemented short stems. If you go by literature, I think in European world, people are drifting from long stems to short stems, cemented stems. So what are your indications when you would like to put a short cemented stem or when you like to put a long uncemented stem? How do you decide?
I'd probably make it depending on the quality of the bone that I find inside. And if I have a good, adequate thermal canal, I'd like to go with the long stem extension. That if there is no long hip prosthesis coming from the top, I prefer to use shorter stem extensions in those cases where I have sort of a metaphyseal, sort of mushy bone, where I actually want to definitely use zonal fixation with a cone or a sleeve, no matter, doesn't matter which one you prefer. In the end, you need to have adequate fixation in the metaphyseal region in order to provide sufficient rotational stability and fixation for the revision component. I know that the Mayo Clinic actually has published on their 10-year experience with shorter stem extensions, and the results have been great. I've been doing that for about 10 years myself now. The problem with that is that if you don't have a proper cementing technique and you have very poor bone stock, then you see failures. I have seen failures with a higher level of constraint in shorter stem extensions, where I actually have had to go back in there within 2 or 3 years after the index procedure and remove the component. And it came out with a cement attached to shorter stem extensions, especially in those cases where it did not have zonal fixation with a cone.
Thank you. Thank you very much.
Okay. Dr. Clauser, although this question I would like to ask after Dr. Amar's lecture, but still I would like to know for our delegates, what is the conceptual difference between using cones and sleeves?
I think that's always a big argument. I mean, I was talking to Morgan Ridian-Jones about that, and I think he's now actually very much into sleeves. I think the concept of sleeves and cones is basically the same. And the point basically is it's different material. And second of all, I think that the cones, you can basically place your tubal component accordingly to where you want it to be placed and still sort of instrument a cone along with that. But the concept of both of sleeves and cones is exactly the same. And of course, the material is very different.
Dr. Clauser,
a lot of companies nowadays have sleeves.
Would you say that the cones will be used more as a filler and sleeves for stabilization?
No, I would think that both actually provide excellent fixation. So I would think that the concept behind it is very much the same. Basically, it is actually filling up the metaphysis and actually giving adequate stability for the revision component. I mean, we actually, when I still worked at the endo clinic, we used to do something like that with impaction bone grafting. And we saw that with bone, it does not work because we did not create sufficient rotational stability in the revision component. So they failed at 1, 2, 3 years down the line. But I must say that with the cones and the sleeves, this has been a complete game changer for revision knee surgery. So I've been using cones for the past 12, 13, 14 years now. And I can tell you that I have not seen a lot of failures of the cones.
Okay, thank you. Thanks a lot. Dr. Neil, you want to say something? Okay, so I think we should move on to the next lecture by Dr. Neil Seth, where he'll be showing us how to, remove the implant in a revision total knee arthroplasty without causing much bone loss. Dr. Neil Seth is professor and head and chief of clinical orthopedic surgery at Pennsylvania Hospital in Pennsylvania, US. Dr. Neil, over to you, sir, please.
Dr. Sharma, thank you. Can you see my slides?
Yes, sir.
Perfect. So thank you for the opportunity of being a part of this. It's nice to be with some friends remotely, and hopefully this will become in person again sometime in the next few months, and that meeting will go off. So I've been asked to talk about how to safely remove total knee replacement implants. And these are my disclosures, which are not pertinent to this. This is a little bit more of a technique-based presentation. So I have 7 steps that I think you have to follow. So number 1 is you want to make sure you have all the tools that you need available in order to do this properly. Sometimes there are implant-specific tools to remove cement. You have to think about those things beforehand and have all this stuff available before you make an incision on the patient. Right? So this is part of the preoperative planning phase. Second thing is you want to really focus on making a systematic approach in surgical exposure for these patients. This is an image of a patient who's had multiple surgeries before, multiple infections. You can see what the tissue even looks like. And you know when you get to that medial part of that tibia on that exposure, it's going to be tough. The soft tissue sleeve is not going to be great. So you want to make sure that you have adequate surgical exposure and understand that during the procedure itself, your soft tissues will stress relax. So if you don't get your exposure in the first 10 minutes, it's okay. I guarantee that at 30 minutes and an hour, your exposure will be better as those soft tissues begin to relax. Number 3, I actually remove the polyethylene first. So I remove this in extension when possible. So after I've done my exposure, made my arthrotomy, done my synovectomy, the next thing is I will remove the polyethylene. For a patient like this, there's a loose tibial component, taking out the polyethylene and extension is not a big deal. However, a patient like this that has a constrained plastic with a screw potentially through the plastic into the tibial component, this one you're going to have to flex up. But the benefit of taking out an extension is that it opens up more space, has less tissue tension, especially on the extensor mechanism when you flex from an extended position to 90 degrees of flexion to start working on the next component. Step number 4, now I'm going to focus on the femur. And I have a very systematic approach. I've got a short 2-minute video at the end that will go over all of these concepts. But I'm going to remove the medial cement, work posteromedially on the femoral condyles, then work laterally. On the femoral component, the lateral side is always harder to work on because you're dealing with the patella being in the way. Next, again, if there's an open box, the intercondylar notch is another space where you get a lot of scar tissue and debris that you can take out to help with your exposure. And then removing the femoral component, you want to do this axially to help minimize any iatrogenic bone loss when you're removing that piece. 5th thing, now I'm going to have a systematic approach to taking out the tibial component. So you remove the poly, you remove the femoral component. I'm going to, again, work medially first, then work laterally. And the posterolateral tibia is the hardest place to be able to get access to. I will do part of this also in a semi-extended position, maybe with a little bump underneath the knee. So again, there's less tension on the extensor mechanism. I can subluxate it laterally so I can really get to access that posterolateral part of the tibia. And then again, axially removing the tibial component to minimize any iatrogenic bone loss. Step 6, the key concept with regards to the patella is, again, I try to minimize the number of times I have to revise the patella. I think revising the patella is challenging to do. Just because once you've removed the implant, you're left with just a shell of bone, and it's sometimes hard to revise that. But if there is a case that you have to revise the patella, so especially in cases of infection, or you have a loose patellar component, patella fracture, something like that, where you have to deal with the patella, I do this last. I do this once I've actually dealt with everything else, because I do not want any undue tension on that residual patellar fragment. When you're retracting and trying to get exposure for the tibia or the femur, I don't want an inadvertent fracture of the patella. And then again, I use a saw blade, I use a pencil tip burn. Again, we'll show you. And the last thing is, if you have an implant that is cemented in place and you've got to remove it, once you remove the implants, you're going to have some residual cement left in the metaphyseal in the canals. Make sure you have the appropriate tools, whether they're just back scratching tools from this Moreland set, cement splitting tools, and if you have to use some type of ultrasonic device to remove cement, make sure you have it available. The x-ray I have up here, this is a 4-peg tibia. You can see how much cement is in the metaphysis. Even though these are 4 short pegs, I can tell you removing this implant is not easy to do. Once you get it out, there's a significant amount of cement that is usually left behind if it's been cemented in properly. So here is the short video that's just putting all these components, concepts in air. So again, I'm taking the polyethylene out in extension. By taking this out in extension, again, I've opened up a little bit more space, and now I can flex the knee up. I typically will check what the line is before taking out the femoral component. Somebody is not on mute. Can we please go on mute? There's some background noise. And then again, I'm systematically going through and taking a pencil dip burr to create a space between the implant and the cement. Here I have an offset osteotome, and again, I'm doing this in a way that I'm following my path and then trying to get posteromedially on the area of the posteromedial condyle of the femoral component. Same exact sort of process on the lateral side. the stepwise fashion, just progressing slowly, taking the pencil tip burr and creating a defect between the implant and the cement, and then going back into that interface, and always taking out this offset osteotome in a side-to-side fashion to minimize any type of bone loss. Following that, I'll take a double-sided reciprocating saw blade and follow the path that I've already created. And again, this I think makes it a lot easier to basically not have any extra bone loss, and you're just following the path that you've already created, and you can safely remove the implant. I will tell you, when removing implants, this is not the time to rush. You do this systematically so that you don't lose any extra bone that you don't want to lose and create a problem that you don't have at the start. And then here we're actually removing the implant. And again, you can see we've lost very little bone, a little bit of cement there, and you've got good condyles. Same exact process on the tibia. Again, I'm starting in flexion if I've got good exposure, using the same type of instruments, using the reciprocating saw blade. And again, to get to the posterolateral corner of the tibial plateau, I will put this out in extension. You can see there's a bump underneath the tibia. There's less tension on the extensor mechanism, and I can work both medially and laterally and make sure that I can really disrupt the entire interface between the implant and the cement, or implant and the bone. And again, this move in flexion, coming from that posteromedial corner all the way to the posterolateral corner, I'll measure how long that distance is first to know that I'm not plunging. And then again, you can actually remove the tibial component, and you can safely remove that without losing any bone. So in summary, I think you need to make sure you have all the tools that you need at the start. Really focus on your surgical exposure to make sure that you can see what you need to see. Remove the polyethylene first when you have the opportunity to do so. So do that in extension to open up a little more space. Next, I'll focus on removing the femoral component. Next, I'll focus on removing the tibial component. And then last, if I have to take out the patellar component, that'll be the last thing that I do. And then again, removing all the cement. I think it's important to have a systematic approach, but I think it's also important to be patient. Your tissues will stress relax, your exposure will get better, and it'll be easier to get these implants out step by step. Thank you for your attention.
Thank you, Dr. Seth, for this wonderful presentation and safely removing the prosthesis. I would request the panelists and the faculty if they have any questions for Dr. Neil. Dr. Ronan Roy, yes, please.
Yeah. Yes, Neil, I loved your talk, actually. One question, I saw that you use the reciprocating saw for the tibial component removal. Do you not find stacked osteotomes as a useful alternative on both the medial and lateral side?
Yeah, so Dr. Roy, I think that's a good trick to have. I've had to use that sometimes when you actually, I think even with the reciprocating saw blade, I've disrupted the surface, but I think the stacked osteotomes done properly can give you that axial force to lift up the tray. I'm just careful sometimes though with regards to those osteotomes, because in really osteoporotic bone, it can still depress the plateau, and you can get a little bit of bone loss if you don't do it right.
I think it's important to try and go into the cement implant interface rather than the bone cement interface. I mean, that's where the trick is, I suppose.
Yeah, no, absolutely. And so again, with the saw blade or these offset osteotomes, we're going to the implant cement interface. I'm not trying to get down to the bone. But again, even with osteoporotic bone or people who have been multiply revised, that bone stock may not be great. So just have to be careful, I think, using that technique, but that absolutely works.
Yeah, Anil, you have a question?
You need to unmute
yourself.
So sometimes you get a patient to revise in which primary knee the surgeon had used a stem on tibial site, like an rheumatoid knee or an obese patient, and you have to revise that knee. And what are tips you would suggest to remove tibial plate with stem? How do you take it out? Supposed to be cemented partially.
Yeah, so that's a good question. I think that you have to be ready to do some more advanced techniques in some of those situations. So again, I think the technique of removing the tibial component is not any different. I follow the same steps, and then I take a look, see at what is my ability to remove this implant. Depending on the implant, sometimes you have the stem at the Morse taper junction between the stem and the actual keel of the tibial implant will dislodge, so the top piece of the tibia will come out, but the stem is left behind. If that's the case, then I've got to use techniques to get out that stem piece itself. Problem is when it does not come out as one piece or you cannot disengage it. Those are the times I think that you have to be ready to do a tibial tubercle osteotomy to be able to access that interface between the cement and the implant, between the bone and the cement, to be able to remove that implant safely.
Thank you. Thank you.
Dr. Neil, one problem. Yeah, Rajkumar, you have a question. Please go ahead.
Yes.
Yeah, this is in continuation. Hi, Neil. This is continuation with the stem removal of the tibial side, which you mentioned. So sometimes in the femur, particularly a cemented stems, okay, then that's what you said, if the femoral component disengages from the stem and that cemented stem in the femoral side, so you have to split it, and then any quick tips and tricks to do that?
Yeah, so I think there's two tricks that you can use. So what Dr. Rajkumar is talking about is you've taken out the femoral component. The component itself has come out, but the stem has been left behind, and there's a long column of cement around the stem. So I worry a little bit by trying to use a trephine over that, just because the bone is probably not great, and I think you can create a fracture and create a bigger problem. So I will sometimes do an episiotomy of the anterior cortex of the femur to let the femur relax and open up a little bit. That way I can engage a little bit more of the cement, disrupt the cement, and then see if I can get this implant out. I haven't done this yet, but I know that Tom Faring's group down in North Carolina have described this anterolateral window that you can open up, almost like an ETO of the distal femur, again, to give you more access to that area of the cement interface, to again, disrupt as much of that as you can so you can take off the implant. I also have a very low threshold to put a wire around the femur if I'm going to be doing some of that work, just to not create a split that can propagate up and become a bigger problem going proximally on the femur.
Yep. Thank you. Thank you.
Dr.
Amar has a question or a comment, maybe.
Yeah. Dr. Amar, please unmute yourself.
I was just going to say that with, with any stem, you need to understand the nuance of the stem. Is the stem offset? Is there any sort of waste in the stem? If there is, removing it is extremely difficult because the cement forms around that waist or around that shoulder on the offset. So the only way, you can get big slap hammers and attach them to implants and bang them out really hard if you have a tapered stem. But if you have any sort of waist or any sort of shoulder, those implants won't come out as one piece.
Very right.
Dr. Asit, you want to ask? Unmute yourself, please. Dr. Asit, unmute.
Yeah. Okay. Neil, hi. So in India, we are not using uncemented knees, but I'm sure in US, you must be using uncemented knees. What is your experience in extraction of those implants? Is it more difficult? I'm talking about non-infective, knees, which you have to remove. It's uncemented.
That's a very good question. That my experience has not been that great in some cases. Those are hard to remove, especially the ones where the patient comes in, they're not infected, they're painful. You see radiolucent lines on the X-ray. You see the bone scan that shows a slight bit of uptake around the component, and then you go in and say, "Yep, this should be loose," and it's not loose as loose as you thought. Again, I don't think the technique changes in the sense of how we're taking those implants out. I think the same thing is true with regards to, there's now no cement interface. So now you're really bone implant interface. You have to really be meticulous about trying to get as much of that interface disrupted as possible. I worry about the thermal necrosis that I might be causing by now going across and really spending a lot of time in that interface. But they can be challenging to take out, especially if they're really well fixed. And then I think there's a higher likelihood you may get some bone loss. And this, especially around the tibia, I think is a little bit harder to deal with. I was going to make one comment, Dr. Sharma. So with what Amar said, he's absolutely right. When there's that waste of the prosthesis, or even if you have a cemented stem, that Morse taper junction, you can get cement actually incarcerated around there. Now all of a sudden it's not one piece. One of the tricks that I use if I'm putting in cement, or even if I'm doing a hybrid cement fixation, I will put a little ring of bone wax at that junction between the implant and the stem, so that there is no cement that gets stuck in that little groove. Because now you've got the stem that's fixed with cement, you've got cement that's stuck between that groove, and then distal part of the implant. So that allows, I think, that whole piece to look as one piece when it's coming out of the cement.
Last question for this lecture to Dr. Amar and Dr. Neil both. How to remove a well-fixed sleeve?
That's a great question, because I ask Amar this question every couple of years when I've heard him give this talk. I've had to remove, I think, less than a handful of sleeves. They are very challenging to remove. And especially when your stem is larger than your sleeve, which means the sleeve has been put on to the undersurface of your implant and the stem is put on after that. Yeah, I mean, Amar, any tricks on how to, I know you use more sleeves than cones. Any tricks on how to get them out?
Yeah, I mean, first, I agree with you 100%. On the tibial side, I will tend to go with a longer stem that is 14 millimeters or less. That allows me to pull it through the sleeve. If you go with a bigger stem, yes, you can go shorter and get a better press fit, but it will make it difficult to take out. So I'd much prefer to go 14 millimeters and go long and get 3-point fixation. And I'll show some examples of that later. Yeah, I mean, if they get ingrown, I do a couple things. If it's infection, oftentimes I will leave the ingrown parts and remove the parts that I can easily remove, just like I might do with an AML stem, a fully porous coated stem. I try not to take them out if I don't have to, and if the infection recurs, then you have to do big ETOs and tubular osteotomies. So they can be taken out, but you can do a lot of damage taking them out.
Okay, thank you. I think we should move on to the next talk. We'll be running short of time, and we'll invite Dr. Phonthakon Panishkul from Bangkok. He is a senior consultant joint replacement surgeon at Bangkok Hip and Knee Center. I welcome you for your talk on prosthesis selection and revision totaling arthroplasty. Please, Dr. Phonthakon. You need to unmute yourself and share your screen, Dr. Phonthakon.
All right. Okay. So do you see my screen?
Yes, yes.
All right. Thank you so much for the invitation here. My name is Phonthakon. You can call me Paul, easier for you. So today we'd like to talk about the rationale of the prosthesis selection in the revision TKA and from Bangkok Hospital, Thailand. So this is my disclosures. So we talk about the factor to do a decision making for the revision TKA. We have to think about beyond the X-ray. We have to know the cause of the failure. We have to know that it's septic or aseptic loosening or something. We have to look beyond the X-ray right now. The patient is a high BMI or the neuromuscular impairment, but the two main problems that we have to address is the bone loss and the instability. So we have to focus for two aspects right now. The instability, we have to make sure that during the surgery, after the revision, we need a stable knee joint to restore the joint line and stable range of motion. And this type of the problem, we have to think about the constraint of the prosthesis. The second one is the bone loss. We have to do the bone stock reconstruction. That's why we have to talk about the metal augment cone on the metaphyseal sleeve right now. So we go with the first one first, is the instability. The fundamental principle of the revision is to choose the prosthesis with the minimal limit needed to manage the instability. It means that we need to use the least constraint first, and sometimes we need to get with the higher constraints such as the semi-constraint, valgus and varus constraint, or at the end, maybe we need a hinged knee prosthesis. This picture show that about the least constraint to the highest constraint. And the increased level of the constraint stabilize the knee by replacing the ligament, the absent ligament function. But we start with the minimal constraint. For the minimal constraint on knee, the PS design is the minimal constraint for the revision TKA. Sometimes we have to use the ultra congruent or deep dish articulation to provide more stability during the revision surgery. But we have to know that when we use the PS design for the revision, we need the full function of the collateral ligament and also the minimal bone loss from the previous prosthesis removal. This case, this is the UKA revision, we have to remove the UK prosthesis, and you can see that after we remove the prosthesis, you can see that the bone is still have a good bone stock, and we can use the PS design as a revision as the primary prosthesis for the revision TKA. The next step is the varus and valgus constraint prosthesis. These type of the prosthesis produce the valgus and varus stability because of the elevated tibial spine, deeper in the condylar box, and also provide the stability in all magnitudes, both varus and valgus, AP stability, and also the axial rotational stability. And this can use with the stem, augment, and wedge, and also the sleeve. And these type of the prosthesis I use in both of my revision surgery, and indication is for the incompetent collateral ligament. So this is example of the case. You can see that there's a lot of bone loss and have some collateral ligament deficiency. We have to put the cone, and also we have to put a sleeve and extend with the stem at the diaphyseal area. And because if we use the constraint prosthesis, there's a more constraint and also the stress at the prosthesis cement interface, and that's why we have to add sleeve or stem. The last one is the high constraint prosthesis, or we call the hinged knee, and which is rarely used right now for the rigid design. But with the modern design as a rotating platform, this is a good design that reduces the stress between the implant and bone interface, and the offload a sharing force on the prosthesis bone interface and have an excellent outcome. And the indication for the hinged knee is the massive bone loss, gross ligament incompetence, severe bone osteolysis, such as the soft tissue defect, and also with the combination of the severe varus and valgus, deformity with the flexion contracture and recurvatum. And sometimes we have to use in the polio case, such as the neuromuscular disease. This is the example of 78 years old female, have multiple recurrent dislocation after revision surgery. We did the hinge design to this lady. You can see that after the surgery, the knee is stable. And the last one is a mega prosthesis, a reconstruction after tumor removal. But sometimes we need to use this type of prosthesis in the multiple revision setting after the previous infection, and also the pelvic fracture, which have a very insufficient bone stock, and also the massive osteolytic lesion from where they be. This is 96 years old female, have the multiple left knee revision 16 years ago. You can see that there's very small bone stock left. So that's why we have to think to use the distal female replacement for this lady. She's really old, and we need to do very fast for the surgery for her. Another case, 80 years old, have the multiple knee revision. We have to put the distal female replacement for this lady also, because of there's no bone stock left. So the second one is the bone loss. We have to think about the bone stock reconstruction. That's why we have to think about the metal augment. And before that, we have to know the classification of the bone loss as the AOI classification. Type 1 is intact metaphyseal bone, type 2 damage of metaphyseal bone, and the type 3 is the majority of the metaphyseal bone is deficient. And to make it easy, the type 1 and type 2, you can use a standard PS standard PS design, or the VV constraint knee in some type of the case. And because we have to add some bone graft or the metal augmentation. But in the type 2B and the type 3, which have more severe bone loss, we need to think about the VVC constraint. Also, sometimes we need to use the rotating hinge knee design, because we need more stability and reconstruction with the bone loss. And as the previous speaker mentioned, this is the classic paper regarding the zone of fixation in the revision knee replacement. The principle is we need a solid fixation to at least 2 from T zones in these pictures. This is the framework for the implant selection and pre-operative planning. For the metal augment, we use for the very small bone loss, such as the very bone defect less than 1 or 2 centimeter. There's a wedge and a block design, but as everybody know that the block design have a better resistance to the compression and the deformation than the wedge metal augment design. This is an example of the 80 years old lady have a failed left TKA. You can see there's a bone loss at the medial tibial plateau. And that's why we have to add the metal augment at the medial tibial plateau. The metaphyseal sleeve is that's a very famous and uses right now. You can see that it's easy to use, and it's a gather step geometry to maximal contact at the zone 2 and zone 3. And there's a compressive load between bone and the implant. It creates strong foundation, and this is tight fit between the sleeve and the bone. After we use that, you can see here the indication for the metaphyseal sleeve is metaphyseal cavity defect. The fixation range from zone 1 to zone 2 or zone 3, and the massive bone defect at the metaphyseal area that we cannot restore with the metal augmentation. And this is the example of the case here. You can see that there's a severe bone loss at the metaphyseal area and also the condyle of the femur. And we use the hybrid technique to cement at the prosthesis, but not at the sleeve. And also the stem, we use the place fit principle design. The second one is the cone here. The cone is an excellent, also inductive property. It's created from the tantalum or the titanium. And it's just like the metal filling defect as we discussed before. And it's a biologic fixation happens just only from the external surface, not the internal surface. That's why if we use the stem combined with the cone, we need a cement fixation. So different about between the cone and the metaphyseal sleeve is when we talk about the cone, we have to think about the metal augmentation. It's like a metallic bone graft to fill the defect. But we need the cement that stem to combine with the cone fixation to create the zone 3 fixation. But with the talk about the metaphyseal sleeve here, this is a dual function for the implant fixation and also the augmentation. And the sleeve attached to the femoral and the tibial component, and it allows the prosthesis fixed into all the 3 reference zones. Here for the stem, when we talk about the stem, how long for the stem that we use, it depends on the defect of the patient, because the stem can do a load sharing between the bone and also the prosthesis. It's like acting like a bridging, bypass the defect down to the metaphyseal and the diaphysis area. The indication is remaining bone stock is not sufficient to support the implant, and we need to use the constraint prosthesis. That's why every time we use the constraint prosthesis, we need to add a stem or the sleeve. And it demands for the case that we have to correct the hyperextension of the femoral component. There's a 2 types of stem. Metaphyseal engaging stem is the cobalt chromium stem, which is a very short stem here and need the cement, bone cement for fixation. The second one is the diaphyseal engaging paste fit stem. It's made from the titanium alloy. It's longer than the metaphyseal stem, and you need a hybrid technique for the fixation. We do cement at only the tibial tray surface, not at the diaphyseal area of the stem. And it's made from like a conal and a spine design. This is the example of the metaphyseal engaging stem. 85 years old female, have very small leg, small body, and severe osteoporosis. And we did the metaphyseal cemented stem for this lady to make sure that it have a stable fixation. Another one is the example of the diaphyseal engaging paste fit stem. This 76 years old, we use the hybrid cementation technique to fill the cement only in the proximal area, not the distal area. So in conclusion, this is the guideline for the cone sleeve usage and also the prosthesis selection. So you can see that we have to think about the bone loss, and also we have to think about the constraint of the prosthesis. This is we wrote it down in the textbook in 2022. And in conclusion, we have to think for the instability, we have to think about the stability of the knee joint, think about the constraint prosthesis. For the bone loss, we have to think about the metal augmentation, cone, and also metaphyseal sleeve. Thank you so much for your attention.
Thank you, Dr. Fonthakon, for giving an explanation about what implant to use and the difference between sleeves and cones. Do we have any questions? Dr. Ronan, you have a question? We'll just take one question for this talk because we are late. We'll be running on to Dr. Amar's talk after this question. Dr. Ronan, please.
Right, just a quick one, Paul. Do you have any algorithm that you follow for increasing your level of constraint when you're doing a revision? When you decide to change over from a varus valgus constraint to a hinge type prosthesis?
For the varus valgus, we have to make sure that the bone stock of the patient looks pretty okay. And for the hinged, and for the if I will use a hinge in the case that they have a global instability of the knee joint, but the varus that cannot maintain the stability by the VV constraint knee, such as the multiple dislocation of the knee, and also the neuromuscular disease of the patients, and the polio or the very laxity knee that we cannot restore with the varus valgus because it's global instability. That's why we use the hinge knee.
Okay, thank you. I think we should go into the next talk by Dr. Amar Ranawat, and he'll be describing us the use of sleeves in revision total knee arthroplasty. Dr. Amar Ranawat needs no introduction to the Indian arthroplasty scenario. He's a wonderful surgeon, an amazing teacher, and a great mentor. I've had the opportunity to work with him. Thanks a lot, Dr. Amar, for joining us and sparing your valuable time. Over to you.
Thank you. Can you see my slides?
Yes.
Great. So I'm going to follow up a lot on what was just talked about and give a little bit of a different interpretation. These are my disclosures. My family and I do get money from DePuy, but not for the revision product. So, the basic steps we've talked about: prepare the tibia, prepare the femur and the patella, restore the joint line, and then reconstruct the bony defects. One point I want to make is whenever I do my trial balancing, I use PS trials. Even if I'm going to put in a constrained insert, I think it's very important to make sure you have PS trials, because if you use a constrained insert, you won't get a good sense of what your soft tissue sleeves are like. The technique is relatively simple. It's been described. You ream. I ream on power distally to get a good press fit. Then you can ream more proximally, open up the proximal tibia. You put the sleeves in, you get a good press fit and wedge with your broach, and then you cut off the remaining bone so you have a nice flat cut surface, and that's how you do the revision. That's totally BS. If you're doing a revision in this type of situation, you don't need sleeves, right? If I was doing this revision, I would put a bigger sleeve in, and I would be above the bone, so I won't remove the bone. I'm going to talk about the use of sleeves in a situation where the sleeve is completely taking the entire load of the implant. We're not sharing it with the condylar surface. So this is the way it's described: to share it with the condylar surface and do a hybrid fixation. I'm going to talk about doing it completely non-cemented, where it is unsupported by bone. On the femoral side, it's very similar. You ream distally, you broach proximally, and you get to a place where you have, a good interference fit. If you have good condylar bone and you're going to cement your prosthesis to the condylar bone, you don't have to have a good press fit on your sleeve. Your sleeve is just there to fill the space and to have secondary ingrowth later on. But if you don't have good condylar bone and you're going to rely on the sleeve, then you must have endocortical contact, and the sleeve must be completely well fixed. Then you do not need condylar contact. Then I do not use cement. Some pearls: if you're broaching in these revisions, the bone is sclerotic, there's retained cement. If you broach only, you're going to get into trouble. You've got to use as much reaming as you can, and you got to use high-speed burrs to remove sclerotic bone and cement. Then you can broach gently. If you follow the surgical technique only, you'll find yourself cracking the femur, cracking the tibia, and having to put in wires as such. If you've put it in without cement, like I did on the on the femoral side, you can back the femur out, put the cable across, reduce the fracture, and then impact the femur back in. On the tibial side, where cement was used, I just recommend putting the cable around and not taking it out. In both of these examples, you can see on the femoral side, I put in a larger stem. That creates a waste, and if that can make it difficult to remove. On the tibial side, as you can see, I've kept it under 14 millimeters, so I can pull that sleeve out of, I can pull that stem out of the sleeve. So your fixation options, you can cement these things in entirely. You can do hybrid fixation where you just cement the condylar surfaces. Or you can do them all non-cemented. Nowadays, the only time I use cement is really when I want to deliver antibiotics, not for fixation. And I always prepare the tibia first. It's very easy then to go. I could put a PS insert in, a constrained insert in, or convert to a hinge or a DFR very easily. As we talked about before, if they do get ingrown, it's very difficult to remove, and you need a Winquist, heavy slap hammers, and often you need to do osteotomies of the anterior cortex of the femur or tibial tubercle osteotomies of the tibia. So therefore, I always think about how much porous coating I need. If I have good condylar bone, I'll use a partially porous coated sleeve. And if I'm relying 100% on my sleeve, they'll be fully porous coated. Here's an example of a tibia that's fallen into varus. I have a sleeve. You can see I've used the technique that the company described with cement under the interface. I've become so dissatisfied with that technique that I moved away from it. Here's another example with femoral loss. Have a stem to bypass the defect, have a sleeve. There was some condylar bone, so I used some cement at the condylar surface. The tibial side was, the bone was okay, so I just cemented in a MBT tray. This was a complex primary with rheumatoid with large cysts. And on the tibial side, it looked perfect for using a sleeve. So I used the sleeve just to fill that void, cemented the surface. You know, these are rare situations where sleeves can be very, very valuable. But again, it's not doing the bulk of the work. The bulk of the work was being done by the proximal bone on the tibia where the cement was being placed. But as I got to more and more complicated situations, I had to rely only on the metaphyseal because we had no no condylar fixation options. And this is where the sleeve is doing all the work. So now you have the sleeve touching the endosteal cortex, the sleeve touching the endosteal. This is fully weight bearing. You can have confidence with this hinge that you can weight bear as tolerated with these sleeves right from the get-go. We described our grading system because you will occasionally see radiolucent lines around these sleeves, but it doesn't mean they're loose. So we put in 20, we followed them for several years, and 18 looked perfect. There were a couple that had some radiolucent lines, but none of them migrated, so none of them are loose. So be very careful if you see radiolucent lines around them and you think they're loose. Multiple other authors have shown similar results with very high, greater than 95% survivorship of these sleeves on both the femoral and tibial sides. They very rarely subside. So I would use subsidence and migration of the sleeves as an indication for loosening, not radiolucent lines. More studies support the same. More studies to support the same. Very low rates of reoperation and aseptic loosening with sleeves. So I'll go through a couple of cases really quick. Here's a young person who has a very, very complicated knee. You can see the tremendous tibial bone loss, both on the condylar side and on the lateral side. I need to bypass that defect distally. So we did our templating and our pre-op planning. She has no ligaments. She's probably going to need a hinge. We ruled out infection, got CT scans to evaluate everything. We talked about the exposure, wide exposure, debridements, using imaging intraoperatively to get past the defects. We were able to get a stem all the way down. The sleeve is doing all the work. There's no cement on this tibial side. Same thing on the femoral side. The sleeve is doing all the work. There's no condylar support with a hinge, and she was fully weight bearing immediately afterwards. Here's another case. Interestingly, a very large man, obese, who has a right knee amputation below the knee. So you can see his amputation over here. So he put all his weight on his left leg. He's got loosening and failure of his left knee. We put in a fully porous coated sleeve that is totally unsupported medially. I've never seen one of these base plates break. You can see my sleeve is 14 millimeters, so I could take that out if I had to. On this femoral side, the exact same thing, fully porous coated sleeve that is completely supporting all the weight with a hinge. As I mentioned, this is his only leg, so he's using this leg extremely with all his weight. Final example, tibia that's fallen into varus. Put in a long stem. So this is my my new concept. I go very long on the tibial side. I have my sleeve in. As you see, I don't cut the bone. I leave the bone where it is. I put a bigger sleeve so I can elevate the joint line. I don't worry about defects. I leave them empty. These plates are very durable. They won't break. It looks scary, but you have to get used to it. This is my construct of the future. If this were to get infected or anything else, it's very easy to take the sleeve out because I've kept this under 14 millimeters, and then I can get the rest of the sleeve out with a burr from the top. So this is my new construct. Now, the story's not over. She did, because I went so long, started to get end of stem pain over time. At first it was mild, and then later it got more severe. You can see in the video here, she has, it's touching in the front where the bone is bending around the tibia. It got to a point to where it was disabling. So what did I do? I went back in. The sleeve was well fixed. I was able to pull the whole construct out, took off the sleeve and put the tibial base plate back in. Fully weight bearing. Immediately afterwards, all her pain is gone. 5 months later, all her pain is gone with a fully ingrown sleeve. So you need to do good preoperative planning, need to have good preoperative imaging. You obviously need to rule out infection. Exposure is key, implant removal is key, debridement key. As far as I'm concerned now, 90% of my major revisions are completely non-cemented. These sleeves can do all the work. I will use TC3 constraint and or hinges very, very frequently. And, you know, it's wound care. All these things are critical in revisions to make sure, limiting motion in the beginning to make sure your wound heals. Thank you very much. And I apologize for my voice.
Thank you, Dr. Amar. That was a great presentation and giving us all the details about the metaphyseal sleeves. I would like our esteemed faculty to ask a question. Dr. Rajkumar, you have a question? Please.
Yes, Dr. Amar, that was a very good talk as usual. A quick question about your last case. And there was a minimal bone loss on the medial tibial condyle, and already you have used a sleeve. The reason for the long stem, you said that the new technique you are now following. Why is that such a long stem you have used?
So, you know, when I first started doing these cases, I would do a shorter stem that was press fit very hard. In order to do that, you needed usually to have a 16 millimeters or 18 millimeters to get into the tibia. If you do that, you can't pull the stem out through the sleeve if you have a problem. So now I'd rather go to 14 millimeters because I can pull that out and go as long as I can to give me a 3-point fixation, to give me my initial stability. Occasionally I'll go without the stem at all, but that's not something I recommend initially. I think the stems are very valuable, and I go 14 millimeters or less, and I go as long as I can.
Okay, thank you.
In continuation with this question, Dr. Amar, when would you use sleeves without stems? When and why?
I think if the sleeve is getting you into trouble, I think Dr. Krauser was alluding to this, right? If the bow of the femur or the bow of the tibia causes you to have to use an offset sleeve or offset stem, those are situations where I would just use a sleeve and not the stem.
A short stubby stem, and you're now using a longer stem. That is what you've shown in your presentation.
Well, yeah, so if I'm going to go, if I can get the long stem in, then I'll do it. But if it's going to interfere with my placement of my implant proximally, then I won't put it on. I have confidence in the sleeve doing enough work that you don't need stems all the time.
Dr. Ashit, you have a question?
Yeah, so, you know, the paper that was quoted, Reed Morgan Jones, you know, the zonal fixation. If you have good fixation in zone 1 and zone 2, so that is epiphysis and metaphysis, still would you use the stem or you don't use the stem?
Exactly. So I don't think you need to. So I prepare it with the stem. I put my brooch has a stem on it while I'm preparing it so that I know. But then if you have good condylar bone in zone 1 and you're going to cement that, the sleeve is just a secondary support for later ingrowth. it's not doing the work. So I don't think this, the stem is adding anything either there. So there are plenty of circumstances where you don't need to use a stem, but I always use it while I'm preparing the sleeves.
Can I add to that comment that Amar just made?
Yes, Nikhil.
Yeah, so exactly what Amar said. During preparation, many times you have altered anatomy, and the previous knee replacement has created a track that if you start with the sleeve directly, it will lead you to cause a perforation or fracture. So it's very important, even if you plan not to use the stem, to prepare with the stem because it gives you the correct alignment in the diaphysis of the tibia. And then if you get really good axial support by the sleeve and good torsional support, then you don't need the stem.
Thank you.
Exactly.
When we are talking about the sleeve, Amar, you'll agree that in a smaller bone, one has to be more careful that you may have a fracture.
I mean, listen, if you do orthopedic surgery, we fix fractures and sometimes we cause fractures. And if you cause it, you better know how to fix it.
Yeah.
Okay.
Right. So putting a cable around the proximal tibia is a little daunting for some surgeons, but you can do it. You just stay on the bone and you elevate the soft tissues in the back, and then you can get a cable around it. You can put wires like you would do with a TTO, through it, and sometimes you can put the sleeve around the wire. So there's lots of ways to fix these fractures if they occur. But that's why, as I said initially, using a high-speed burr to create the sleeve preparation is, in my opinion, much more safe than using the broaches. I rarely use the broaches because they tend to fracture in sclerotic bone.
Very right. Ronan, you have a question?
Just a short one, really. Amar, just going back to the last case that you showed, if you'd used a 14 millimeter stem, but you'd used a shorter stem, would you have circumvented the problem, you think?
Well, so if you use a shorter stem, you don't need a stem at all, because remember the 14 millimeters is not diaphyseal engaging, right? So I'm using the length of the stem to get me 3-point fixation. And remember, that 3-point fixation is what you use initially to allow that sleeve to integrate. And once it integrates, then the sleeve is not doing anything. And because it was causing pain, then, I removed it. So yes, I mean, it all, because she had such proximal bone loss, sometimes you need some adjuvant stems to ensure you get ingrowth. But if you don't need it, then you don't have to use it. That much I agree.
Okay.
Thank you, Amar. I think this was the last question, and
yes,
we'll move on to the case discussion now.
Yes, let's invite the first case, which is being presented by Dr. Sanjeev Jain from Hiranandani Hospital. He's a director and joint replacement surgeon at Hiranandani Hospital, Powai. Dr. Sanjeev, over to you, sir. We can see your screen. Thank you. We can't hear you, Dr. Sanjeev Jain, sir.
All right, now can you hear me?
Yes.
Yes. So thank you, Mrinal, and thank you, IAA. There are just only 1 or 2 cases just to talk about instability in revision total knee replacement surgery. Of course, these basic principle has been talked about all the 4 earlier speakers, and I think they have wonderfully explained all the basic principles, how to do it, and what are the ways one has to perform the revision knee replacement surgery. So my first case here is this lady. She was around 110 kg, presented to me, no earlier x-rays available, 6 months post-op with this kind of x-rays, with the pain, inability to walk. She had bilateral stacked knee replacement done somewhere else. She had a history of slight oozing, but initially, but the infection workout that time and when she presented to me was negative. So naturally, there was some fishy thing was happening here, and I can see this medial side was little more pronounced. So we did her varus and valgus X-ray, and we did find that definitely there was an instability, and probably the femoral component was also loose. So we went ahead and planned as per all the principles of revision total knee orthoplasty, and this was a condition after removal of implant. This was an extension. This is the femur. This is the tibia on this side. This is the inflection. And if you see the medial side, the fragment, if you go ahead, go back here, this medial fragment here, okay, was possibly either a secondarily or a primarily had an injury. And this has led to a complete instability. And of course, naturally, because of the unstable femur as well, there was a lot of bone loss. So we went ahead and we did a revision surgery using a sleeve on the femoral side, and of course an MBT tray on the tibial side using an hinged knee. And we could also maintain the joint line and stability definitely perfectly. And this was the final X-ray. I had to cement because she was a very heavy lady, and I had to cement both the side, the stem. I prefer to do a cemented stem on both the side for this particular patient who was very heavy, and this was the final outcome. And she had no infection. This is around 6 to 8 months post-op now, and she's doing quite well. So instability can be classified. There are other classification, but extension instability, which could be symmetrical or asymmetrical, flexion instability, many people talk about mid-flexion instability, and the global stability. So another case talking about the global instability. This patient who had 3 years post-op attuned CR knee done, and she had a fall. She was 70 years old, and definitely, as you know, this was an unstable knee, global instability, which is due to the post-trauma and post-fall. And if you see an extension and inflection, even this is a cruciate which was also ruptured, and there's a huge soft tissue damage, and which needed a definitely a constrained implant, and bone quality was also poor and soft. So we went ahead and did an hinge knee using a sleeve on both the sides, okay, maintaining the joint line as well, stability perfectly. And finally, I'm sure that Amar, if he's there, he would love to see this X-ray. I did also use a long stem on a tibial side, and which was not impinging anywhere else, and we could maintain the joint line. And finally, she had an excellent result, and she's doing well. So to talk about the few words on instability in total knee scenario, one of the major cause for total knee replacement, which was earlier, was aseptic loosening or infection. The instability is taking the higher score, and which are many papers to produce and see that the instability is one of the major cause. The basic principles remain the same. You need to have all the principles: balancing, alignment, ligament, and of course, the most important thing also to maintain or bring out the joint line in a proper place. And once you do that, then results are really excellent. Use all the methods to preserve the joint. So instability is one of the dangerous thing, but we need to identify the real type of instability, and definitely finally the type of implant which you're going to use. It has to have in your armamentarium, and you can give an excellent result. Thank you so much.
Thank you,
Dr. Sanjeev. I would request the case presenters to stick to one case only, and this case is open for discussion now on instability and joint line restoration. Let's hear it from the panelists, Dr. Manoj, Dr. Anil Arora.
I want to ask a question. Yeah.
Yes, Doctor.
Dr. Sanjeev Jain, good cases, clear message. Just one curiosity. In case 1, where the patient was obese, a negative point, and you used an hinged implant, linked hinged implant, with a lot of strain at the implant bone interface. You did not use sleeve on the tibial side.
No, but it's an RP, it's rotating platform, so it will definitely not put a lot of strain on the implant bone surface. And the sleeve is only used here, and the stems are cemented. So it's not a fix, it's a rotating platform implant. So possibly what you're talking about, the stresses will be less.
Dr. Amar, would you like to add on something?
Yeah, no, I think a great case. Listen, whenever you do a hinge, you have to be confident in your fixation. Again, I'm not sure about the proximal cement, what it's doing. I would make sure that my sleeve on the tibial side is really, press fit. And I often, as I said, I'll put in a bigger sleeve so that it sits up above the bone. That gives me confidence that it can subside a little bit and seek a better seating in the bone to get ingrowth. So as I said, I've abandoned using cement on the condylar surfaces, and I rely on press fit of the sleeves.
So the message is that you should not use cement on the undersurface because that violates the principles of sleeve fixation and it does not let it subside and integrate. That is what should
Amar, one question.
Yes.
Do you use when you are not using the cement with the tibial component, you're using the cementless tibial component. Is it right?
Yes. Yeah. Yeah, the tibial component has a porous coating on it.
Yeah.
And now, most of my experience has been with the PFC Sigma system, where their sleeves on the tibial side only had a partial coating. Because of our relationship with the Pew, at some point I was able to get a fully porous coated sleeves, and I like them a lot more. And now with the Attune system, you can get those too. So, like I said, if you have good condylar bone and you're going to cement the condylar surface and you're not really worried that much, use a partially coated sleeve. Right. But if you don't have any good condylar bone, use a fully porous coated sleeve and keep it a little bit above the bone so it has a little room to compress.
Right.
So let's go on to the
same
next
concept like in a hip. If you're going to do a non-cemented hip, you shouldn't have a collar. Right. I mean, I'd be happy to argue about that with anybody, but you need these implants to have that slight settling ability. And so having a collar to me makes no sense. I don't want my tibial base plate to prevent my sleeve from seeking its preferred position.
Right.
Okay.
Now we move on to the next.
Yeah, we move on to Dr. Rajkumar, our own IAA secretary. Is going to present on hinges in revision totaling arthroplasty. And Dr. Manoj, you are going to answer the questions.
Okay.
Get ready. Okay.
Yeah. Can you see Mrinal?
Yes. Dr.
Yeah.
Rajkumar,
okay. Thanks, Dr. Mrinal, and thanks, Dr. Rajiv, for the opportunity. Wonderful program. So hinges in revision total knee replacement. Actually, Dr. Sanjeev has already showed two cases. So the most common reason why you use a hinge in a revision, first is instability. The second is a gap mismatch in a revision scenario. And the third one is a severe major bone loss, osteolysis due to infection, like a large bone defect or due to infection. So these are the most common three reasons where in a revision scenario you use a hinge. So you try to not to use a hinge as much as possible, but situation compels you have to use it. So the absolute indication, as I told you, major tumor resections, gross ligamentous incompetence, and severe bone loss. These are the three indications, absolute indication. So I am going to show an example which was not shown before, a hinged knee in a post-septic revision, a rheumatoid patient, septic loosening, post-TKR. Multiple revisions has been done in this situation because of the patient had a tuberculosis and started on ATT and then underwent revision. So you can see the major bone loss and so much of cement has been used as a spacer. In this scenario, you will have a lot of ligamentous compromise because of the compromised metaphyseal bone loss. So a revision hinged process has been used. So this is the example which I wanted to show. 71-year-old female, obese, septic loosening, left knee. The problem here is the implant has been there for a long time and that eats away the bone. That's the osteolysis happens because of the loose implants. And because of that, a lot of bone loss happens. So that is itself is a big indication for a need for a revision hinged processes. But that has to be assessed at the time of two-stage procedure. When you remove the processes, you do the thorough debridement. And then in this situation, in this scenario, you decide and also document that what kind of processes this patient will require in the second stage. So here you can see that lateral femoral condyle is almost lost. and so much of gap. So it compromises the ligament collateral attachment, and a huge cement has been used for the deficient bone loss. So a bone loss in a type 3 femur and also in type 3 tibia, management bypass the metaphyseal for stability. And since the collaterals are compromised and the fixation has to be in the metaphyseal diaphyseal, bypass the metaphyseal, better to use a rotating hinged knee in osteolysis bone loss, particularly in a post-septic scenario. So the one quick point about this rotating hinge, it's a third generation rotating hinge where the axial rotation on the tibial plateau happens, which reduces the stress transferred to the bone implant. So this gives an excellent stability, and also the advantage is that the longevity of the processes. So rotating hinge process has a favorable outcome for patients. Its rate of survival is now acceptable. The most common reason for failure of this hinge processes is again an infection. So to conclude, third generation rotating hinge knee, in revision total knee, a hinge knee is used only when there is a less constraining process or unlikely to provide adequate stability. Only in that scenario, you have to use a hinge, particularly in a post-septic scenario. Always keep a hinged knee as a backup in your all revisions. Thank you.
Thank you, Dr. Rajkumar. Excellent presentation. So the question which arises is that the hinges, they require a femoral sleeve, and the femoral sleeve determines the joint line. And in a revision, we have a tight extension and a loose flexion. So Dr. Manoj, how do you manage that?
So basically, I think reducing the femoral posterior offset is extremely important. And in these cases, when you're using sleeves as a parameter, you would just try to restore the joint line. Once you've restored the joint line, and as Amar already said, basically it's a tray has to come at the natural joint line, and you might find a lot of gap between the sleeve and the tray. But as long as your sleeve is nicely impacted and your joint line is restored, you would first restore your joint in flexion and then come back to extension. These are, I think, the two protocols to be aligned to. Once these two protocols are in space, everything else falls back in space.
Okay, thank you, Dr. Manoj. Dr. Rajkumar, you want to answer anything, add on anything?
No, the whole point here is the sleeves gives a very good flexibility in creating the joint, restoring the joint line. So you can impact it little deeper or little prominent outside. Based on that, you have to select the size of the sleeve. And you have to be very careful in Indian scenario, as it was already discussed, particularly when you're using a hinged process, you don't have much bone to play around when you're planning for a hinge. So you have to be very careful in preparation of the sleeve, particularly on the femoral side. So that one important point you have to always keep it in mind. Yes, Dr. Amar?
Yeah, so, I agree that the use of hinges has become much more common. And, I think the error is more often made by not going to the hinge than by going to the hinge. But there are some, tricks and tips. And I think one of them, as we talked about, is making sure you have excellent fixation, because it does put more stress on your fixation. But the other tip I want to suggest, and it's often overlooked, is that if you're putting in a hinge, you need to release almost all the soft tissues around the knee. If there's any MCL or IT band left, it can impede the motion of the hinge. So let the hinge do its job. It's a hinge. It's doing all the work. You don't need the ligaments. So sacrifice the ligaments and let the hinge do the work. It'll work much, much better than if you leave the hinges, if you leave the ligaments behind.
Just one more quick point in continuation with Dr. Amar. Apart from that, also you have to get your rotations correct, because the tracking of patella is very important. In hinged, that you have to achieve it properly. Otherwise, there will be a patellar subluxation. Post-operatively, it's a big problem.
I agree with you. And especially in the diffuse system, the patellar tracking is not good. I think that'll improve with future generations and designs. Attune is addressing it. It's gotten better. But yeah, the SROM hinge is not patellar friendly.
Yep.
So just in case, Amar, if you find patella maltracking few months after you've done a hinge, intraoperatively it is fine, what do you do? Did you get the question?
Most of the time, I ignore it. You're putting a hinge in somebody that they know their knee is not going to be what it used to be. So they just want to be able to stand on their leg and have a knee, have a leg. It's extremely, if the hinge is working fine, I would leave the maltracting patella. If it's really painful or bothersome, I would even consider doing paddlectomy.
Okay, I think we should rush to the next case now. We are running late of time, and Dr. Rajesh Malhotra, our own Professor Rajesh Malhotra, is going to present on allograft prosthesis reconstruct as a salvage and revision total knee arthroplasty. Sir, over to you.
Thank you. Good evening. Thank you, Rajiv. Thank you, Mrinal. So this particular paper talked about the end of the allograft era, talking some bad things about the allograft, but I don't think that's really true. So I'm going to talk about a 25-year-old female who was operated for giant cell tumor of left distal femur in 2009, and as early as 2012, she was reoperated because the GCT recurred, and then she was treated with a mega prosthesis. It worked all right for 7 years. Then she presented to us in 2019 with pain in the left thigh. So this was her X-ray. You can see there is loosening. This was the striker HMRS hinge, the modular hinge, and you can see that there was thinning of the cortex, impending fracture here, and it was eccentric. There was bone loss in the proximal femur. So there was obviously a loosening of the femoral component. We were able to rule out infection. She had a defect of more than 10 centimeter. Fixation was required in the proximal canal. And then, of course, she's very young and she's likely to have a future surgery. And of course, she required an active range of motion. So the choices would have been a total femoral replacement or an APC. And I have said that more than once, that the total femoral replacement is more than like conceding a defeat in such cases. So we ruled out the infection intraoperatively also using the synovasure. We took out the implant, and then we had this distal femoral allograft. We actually used the non-modular femoral component matching the tibial component, and then we prepared the femur, and you can see that since the femur had a loss of endosteal bone and there was almost a cavitary defect, we did the impaction allografting of the proximal femur, and then you can see the impacted allografts here, and then we cemented the component, and like it was said for the hinge, it's extremely important to ensure the proper femoral rotation here also to avoid the patellar maltracking, and then the struts were used, and this was the final fixation, and this is how it looked immediately post-operatively, and this is 3 years. You can see the reconstitution of the cancellous bone here, the endosteal bone, and it's actually quite well healed. The allograft is quite well healed, and this is how she walks. She has been told by somebody that it will last longer if she uses a brace. We have failed to convince her. Just a couple of slides to just illustrate another technique. Sometimes it so happens with us that we don't have a stem available to replace this with an ordinary femoral component here. Similar case, but we didn't have the choice of a long stem. And in such cases, after removing this, we used an anti-grade nail and then interlocked it to the allograft. And this is how it looked. And this has been recently done and is actually almost walking without much use for the walker. So we have talked about this often about mega prosthesis versus allograft debate. And just to summarize, they have both their advantages and disadvantages. But if you want better functional outcome, want to restore bone stock, if you have a young patient, then you are better off using an APC than a mega prosthesis. My final argument is, if a mega prosthesis fails, I revise it with an APC. Thank you very much for your attention.
Thank you, Rajesh.
Thank you, Dr. Rajesh.
Very well shown. Wonderful cases. But Rajesh, my question to you is that everyone may not have the access to the allograft as you have in a great institution. So what do you feel between the tumor prosthesis or mega prosthesis and the allograft in a patient who's plus 50? I think you'll agree that the mega prosthesis is a better choice.
So if you don't have allograft, where is the choice? So
Yeah.
we are, and then, Rajiv, you should not be calling more than 50 years old, because you and me both are above 50 and both of us are young. So talk about old as above 80, don't talk about 50. So
Yeah.
if you have allograft, I would still prefer allograft in a guy of my age.
Yeah. Very nice. Nicely said.
Okay.
Yes, Amar,
Amar wants to say something.
Yeah, I think Rajiv should have a meeting with Dr. Alan Gross, and they can talk about allografts all they want. And I think maybe 4 people will show up because nobody has the access to it. But the work you're doing is amazing, and it's fantastic. And I think in those circumstances that you're describing, your results are spectacular. So I applaud you for your efforts, but it's just not a practical reality for most of us.
Thank you. Let me do it while I can.
Rajesh, last question. What has been your experience in worst cases where you use the allograft and the union has not taken place or some serious complications happen?
So it's a very interesting question, Rajiv. We published in BJJ, that time it was called JBJS British, and we said that the complications like non-union and the stress fracture are seen when you don't have junctional stability. And you will see in all my huge series on allografts, if I have slightest doubt about the junctional stability, I always add on studs, because fractures will occur stability. Similarly, it said that the mega prostheses have a higher incidence of infection, whereas the other series say that the allografts have got higher incidence of infection. Allografts have higher incidence of infection when your bone banking techniques are not proper, and then the techniques are good. But if you are able to ensure good practices, the infection rate with allograft are lesser than mega prostheses.
Very well done.
Thank you. I think we'll move on to the next and the last talk by Dr. Nikhil Shah. He's a senior consultant joint replacement surgeon at Centre for Hip Surgery, Manchester, Wrightington, where I happen to have worked with him as an IOS fellow. Dr. Nikhil, over to you for a new technique of customized prosthesis for revision total knee arthroplasty. Dr. Nikhil?
Can you hear me now?
Yes.
Okay, so I've got 2 cases, but I think with time, I've been asked only to do 1 case. So what is a custom total knee? For me, a custom total knee is to be used, or what it is when you're off the shelf or your commonly used sizes and shapes of prostheses or sleeves or stems or fixation devices will not do the job. And when we have looked at the custom knees that we have done, our common indications are extensive bone loss, very awkward deformities, and all very different size patients, so very small sized patients. So let's look at this case. She's a 66-year-old female, raised BMI, significant medical comorbidities, and she has an ipsilateral uncemented total hip replacement. She presented to another hospital with a shattered distal femoral fracture, which was fixed using standard extramedullary fixation techniques.
Sorry to interrupt you, Dr. Nikhil. Can you make it full screen, please?
Better now?
Yes, thank you.
Yeah. So she had some early issues with her wound, with persistent wound oozing, and in a few weeks, the history was that the wound settled with antibiotics. Unfortunately, she did not make a very good progress, and by 9 months, you can see that the fracture has started collapsing and the metal work has started failing. By April 2014, she has a full-blown painful non-union and is wheelchair-bound, cannot bear weight, restricted movements of the knees, and she also has got significant weight issues. That is the time that she was referred to me. So we tried to exclude infection as best as we can. Her bloods were raised, we had some bone scans, and the appearance was suggestive of infection of the distal femur. So for all practical purposes, the distal femur had become a sequestrum. So at this stage, we have an infected non-union of 4 years duration in an elderly lady with raised BMI and significant medical comorbidities. The various options that were discussed included whether we attempt to refix this, but with an infected non-union and a sequestrum, we did not feel that refixation was an option. The second option was to revise it with a custom prosthesis if required. And the third one was a primary amputation, which understandably she declined. So we did it in 2 stages because it was infected. In the first stage, we took out the prosthesis and basically the whole of the distal femur, which was infected and dead. No organisms were grown despite our best attempts, and we used a static spacer with an intramedullary nail. As you can see, the main concern of using the second stage was the short length of the remnant of the femur available to get fixation with the new custom, and the interval between the uncemented stem and the long nail. So these were the main reconstruction issues. There was a total hip replacement at the top, the length of the stem for a distal femoral replacement, and how do we protect the interprosthetic zone. So this is the custom plan that we get. We tend to use the Stanmore custom prostheses. These have very good data of more than 20 years in tumor surgery, and we have used them for almost 15 years. The planning process is excellent. So you can design your standard sized Smiles distal femur rotating hinge. It can go with 2 size tibial components. There is an HA collar that is attached to the stem. There are modularity options where you can extend the length if required. The HA collar tends to ingrow with the distal femur. And then we can add a titanium side plate like in this, which will also ingrow to the bone and which can be fixed with screws. The purpose of the side plate obviously was to protect the interprosthetic zone. And you can plan it, you can plan the screw holes, you can plan the length, you can plan the coating, and almost everything can be customized based on the needs of the patient and your preferences. So those are the immediate post-operative x-rays of the second stage. And then as we go on with the follow-up, you can see that the plate has been stable. The HA collar tends to ingrow to the bone and you get very good interface. That was a follow-up x-ray at 4 years. And then the COVID pandemic started. So the patient has now reached 7 years and I'm just expecting her to come for a follow-up in 7 years' time. Obviously, the worries are that you have to watch them very carefully for loosening of the stem. But functionally, she has done quite well. And we have managed to keep her leg with a custom prosthesis. If you have time, I'll show you the second case where what happens when your custom prosthesis also fails.
I think, Dr. Nikhil, it would be better we can discuss on the same case. That is.
Yeah, whatever you want.
Yeah, let's have some questions from the faculty and the panelists.
So Nikhil, wonderful case. I mean, a nice presentation. Just one point in this case, when you have a HA collar, does it get packed inside the bone or it is abutting with that?
It sits on the bone, and the theory is that the osteoperiosteal layer jumps over the collar and you get ingrowth and you get interface bonding.
If you could just
Amar, you want to ask something?
Yeah, do you have any experience using a sleeve and a press fit stem?
So in a custom, we don't tend to use sleeves. In a custom, the whole prosthesis basically comes made of metal, and the fixation in the femur is usually with a stem, and we use side plates where we have worries about fractures. I think sleeves work better if your metaphyseal is intact. Majority of the horrible customs that we get to ask to do after 3, 4, 5, 6 divisions is where most of the femur has been chopped out, and in some cases the proximal tibia has been chopped out. But so long as the tibial tubercle and the extensor mechanism is still intact, we can design a custom tibia as well.
Yeah, no, but I'm talking about putting the sleeves not in the metaphysis, but in the diaphysis. So that can be done. You use smaller sleeves and you can get them inside.
No, we don't have access to diaphyseal sleeves at that level. This was practically the mid shaft of the femur for resection.
Any other comments or questions from the faculty and the panelists? Because I have none.
Mrinal, I have worked in Stanmore and I've seen follow-up of more than 2 decades with this Smiles prosthesis. And I think using hydroxyapatite at the junction of the implant and the bone is a great phenomenon. It forms beautiful new bone formation and provides longevity to the implant. You see, our Indian manufacturers, if you see, whenever they give you an implant, mega prosthesis, they don't have anything like this hydroxyapatite junction. And that's why it tends to fail very early. If you use that sleeve at the junction of bone and the implant, and the new bone formation, it provides longevity outside the bone rather. Like you get the sleeve. You get it inside
You have to
the
be
bone,
careful that
outside
you
the
don't
bone.
get cement at the integrals. That's the
Yeah,
only thing.
that's right. That's right. That's right.
Nikhil, these screws are designed in different directions it can go, or it can just, because there is always a stem.
So like I said, it was a custom designed plate, and you can get 3D planning. You overlay the plate on the uncemented stem, and basically you tell the engineer, I want to miss the stem. Where can you put the screws without compromising the integrity of the plate? And he will show you the options, and you select which options you want.
And the length.
The whole idea was to miss the uncemented stem. If this was a cemented stem, I could have just used a standard plate and put oblique screws through the cement.
Thank you, Dr. Nikhil. I think we come to the end of the webinar, and I would request Dr. Rajiv to say a few words.
Thank you, everyone. I think it was a very, very well presented, wonderfully discussed, interesting topics of the day-to-day use. And I think that our all members must have been benefited with this interesting and excellent discussion. Now, I'll just quickly talk about the two things before closing the webinar. The one thing is that stiff knee could be the presentation for the infection. What you see here in this patient, the stiff knee has been sent to 15 degrees. The stiff knee could also be one of the interesting presentation, like in this patient. And you see that we used here the re-sterilized femoral component and a cement tibial component. And the culture that you see here, the staphylococcus was grown out of the 6 culture that we had given. And that's what the first stage and the follow-up of 7 years. So remember, friends, that the infection could also be at every stage when we are talking about the revision joint, then the infection has to be ruled out. And in a situation where you are not suspecting the infection, you must send the sufficient cultures, and every culture has to be taken up for at least 2 weeks period, so that you are sure that whatever culture is growing. And the one last thing about the imbalanced implants, that's what you see in this patient. Careful component extraction, as wonderfully explained by the previous speakers. Even when you have a situation like this, you can follow a simple principles of the revision, the release posteriorly, and then you can have the balance the joint. And with this, you may not always need to use a hinge implant in every patient. You can do a good balancing, and you can use the good implantation. Thank you so much for being with us. Thank you so much, faculty. Thank you so much, Amar, for wonderful explanations, wonderful descriptions. Thank you very much for every faculty. And I think it's a wonderful discussion and wonderful exchange of knowledge between us. My suggestion to our all viewers who are not the members so far, to become the members of Indian Arthroplasty Association. We are already crossing around 800 membership now. We wish that the membership of Indian Arthroplasty Association grows to 1,000 before our annual conference comes up in Coimbatore in October. Thank you so much, and we'll close.